Good morning, everyone. Welcome to this public session of the DHCW Programmes Delivery Committee. In relation to today's meeting, I'd like to make a few notes. Firstly, committee members will occasionally be looking away from the camera. We have a set of papers that we're referring to during the meeting, so please be aware of that. We're planning to take a 15-minute break after section 3 of our agenda today, with a view that we will try and close the meeting by 1:30 at the latest. We won't do formal introductions up front, but what I would ask is for committee members, either when they present or ask a question, if you just introduce yourself at that point, we'll be a little bit more efficient with our time. And with that, I'll now move on to the main agenda, which is apologies for absence in the first instance. We have two apologies, one from Rowan Gardner and the other from Sam Lloyd, in terms of their availability today. And I've also noted that Marion has a schedule clash and will be leaving us at 12:30. So thank you for that, Marion. In terms of declarations of interest, I've received nothing in advance of the meeting. So could I just check with everybody, is there anything you need to bring to my attention with regard to a conflict of interest? Okay, I can see nothing, so we're good to move on. With regard to the consent agenda, we have a number of things there which we're basically being asked to either assure or note. These are consent, so we won't go through the papers as such, but what I will ask committee members is if they've got any questions or points that they want to make, either with regard to the business case for DSPP or the internal audit reports. Could you please put your hand up now? Okay, I can't see any hands, so we'll take it that those have been assured in terms of the business case that you've put forward, Matt, and that the audit reports have been noted by the committee members. We'll move on to the main agenda. The action log, there is nothing in the action log that's open, so we can move on from that. And we'll, Chris?
Hi, David. Yeah, can we just approve the minutes as well? Sorry.
Sorry, I've skipped. Yes, sorry, I've skipped over that. It was at the bottom of my page, which sorry. Thank you for that, Chris. Yes, could I just check? There are two different sets of minutes. There's the full minutes and the abridged minutes. Can I just ask if committee members have got any comments or observations they need to make before we formally approve the minutes? Marion?
I have raised it beforehand as a point of accuracy in the minutes. I'm both present and not present in the private minutes, but I have raised it and I'm sure it's being addressed.
Okay.
Thank you.
Fine. Thank you for that, Mary. Okay, so unless there's any other points, we'll formally approve the minutes from the previous meeting. Okay, thank you for that, Chris. Well spotted. Okay, in which case we'll move on to the programme's overview report, and we'll hand over to our Executive Director's strategy for that.
Thank you very much, Chair. So, hello, Bore da Bawb, Ifan Evans ydw I, Cyfarwyddwr Gweithredol Strategaeth, DHCW. I'm the Executive Director for Strategy for DHCW. We haven't got translation today, so I'll be presenting in English. I just want to take, I think it's an important and significant report that I have in front of members today. I'm really pleased to present this because I think the information which is in it shows how we've matured as an organisation responsible for delivering national collaborative programmes over the last 6 months, particularly since we stepped into our new governance arrangements, of which the Programmes Delivery Committee is part. And I'll come back to that at the end of my introduction. So it's going to be a slightly longer introduction than is usual. Digital Health and Care Wales delivers a whole portfolio of national major transformation programs for digital, as you can see, and there's a dashboard which summarises them, and then on each programme, each of the major programmes, as the committee has designated a certain number of programmes to be major ones, that come here routinely for assurance. And there's a multifaceted portfolio, and it's more multifaceted, I think, than perhaps optimally we would want it to be, because each of these programs has been initiated at a different time in a slightly different way, with slightly different governance, sometimes with a different mix of representation on the program board and some slightly different assumptions on governance. And we're trying as an organisation to consolidate that in order to move the way that we manage programs towards a more standardised and a more consistent mechanism, which is also a more industry standard approach. So we've got a raft of initiatives, including a portfolio management office and portfolio management training for teams and for leads, in order to try to move us towards that kind of industry standard stuff, which will be more robust and then will help us to give this committee more assurance, and through this committee, which meets in public, the whole system more assurance, because we're reporting on behalf of all of NHS Wales, not on behalf of DHCW specifically, because these are all collective programmes. So the things that I just want to highlight in that bit is that these are national collaborative programs. They're not DHCW operating in isolation. We work very closely with our delivery partners and with suppliers very often for some of the major programs. And collaboration is right at the heart of that, as is one of the core values of NHS Wales. They're governed, the programme boards are a kind of combination of representation and consent. Consent is really important there. DHCW doesn't have powers to direct other organisations. We are a peer group with others, so all of the parties that are on those programme boards have got an equal status, and none of them can direct the others, apart from Welsh Government, technically. But Welsh Government does that through funding letters, through approval of business cases, through its national governance arrangements, usually at project initiation stage, and then through quarterly updates that are provided by the programme boards to the Welsh Government. Ordinarily, Welsh Government will appoint the programme chair to each programme and will attend as an observer, not as a voting member. So that thing of consent, I think, collaborative consent is really important. We have then a significant dependency on our delivery partners meaning health boards and trusts, and the organisations that are going to use the digital systems that we're collectively putting together, and on suppliers, because very often suppliers provide the system, and it's one system across the whole of Wales, for example, with quite a high level of customisation and configuration required. So we have to work very closely with our suppliers. And all of these things come together in the programme dashboard that you see. The thing which I want to draw people's attention to first, which leaps out really from the document, is the RAG framework and the self-assessment of the delivery confidence in programs. So delivery confidence is, will the program deliver what it's originally set out to do? In most cases at the moment, what it originally set out to do on time and on budget. And that is an assessment not by DHCW, but by the program board itself in all cases. Historically, programme boards have done that in slightly different ways. They've all used red, amber and green, but red, amber and green means a different thing in different programme boards for a variety of reasons. And we're trying to move towards a consistent framework. So at the front of the deck, you'll see the RAG framework. This is version 2, I think, of the RAG framework, which we're working with programme boards iteratively to try to get to a consistent basis on which they are assessing their delivery confidence in their own programs. And there are 3 main domains in there: domains of time and budget and quality. There's a quote that I quite like. It's like I don't know what, it's probably got a name somewhere in the literature, but it boils down to everybody wants things that are good and cheap and fast, right? So whenever you're making a decision, what you want is good and cheap and fast. But the flip side is you can only have 2 of them at a time, right? So you can have good and cheap, but it won't be fast. Or you can have cheap and fast, but it won't be good, and so on and so forth. And this is a tension, and the 3 domains broadly map to that. And typically in our national programmes, the scope, which means good, or quality as we call it in the RAG framework, that is usually what is protected, because it's locked in through our early engagement in programmes with clinical leads, or because it's a procurement specification, or because it's part of the business case, and therefore the benefits depend on delivering the specification. And in fact, that quality or that benefit is very often enhanced during the life of the programme, because clinical leads or health boards or others will say, oh, actually, we'd like a little bit more customization, or we would like a little bit more local configuration, or we've changed our minds about what it is that we need, and therefore the specification moves. And when the specification moves, then, or if the specification is protected, and very often they're locked into contracts, it's the time and budget that therefore has got to move. And what you will see in that deck is that the quality column is more amber, more ambery, more green. I suppose I'm using in non-technical terms here, but more ambery, more green. And then it's the other columns that therefore have to take the strain on that, and therefore you'll see more red in the budget column or in the time column, because that's where we're forced to, collectively. That's where we're forced to take it. And so that boils down to if programs are over optimistic in the business case stage, then there will be pressure on time and budget as you deliver, and programs will cost more and take longer than was originally intended in the program case. And if you then assess against the program case as in a consistent manner, then you will find that the ratings are starting to slip, and we can see some of that. There is also, as everybody will be aware, a very high degree of financial pressure right across the system. So some of that hits these programs directly through the Digital Priorities Investment Fund. Nearly all of them are funded from the Digital Priorities Investment Fund, and that is a limited fund available, and in fact has been slightly reduced last year and again this year, and that therefore puts pressure on the budget, because programs are then required to cut their cloth according to the resources that are made available to them. And if the budget reduces, then that causes red in that column, if you like. But I think more importantly is that there's pressure right across the whole of the NHS in Wales on resources and on budget and on people and on various other things. And that requires health boards to make choices about prioritisation within their own discretionary capital. And very often, because of the way that the dependencies work, that then rolls back into things that impact national programs. If health boards decide to deprioritise the implementation of a certain program, or to phase it in a different way, or to invest less, in their local implementation teams, that will have an impact on the programs because of that. And ultimately, that is a cause of the wider pressures that you can see in the system. So I think you can see all of that coming through in the dashboard. The dashboard is redder this quarter than it was the last quarter when the program board met. And so I think I'm trying to sort of describe some of the what that's a symptom of underlying causes across the system. So I'll just close with a couple of things. So one is that all of the dashboard is a forward-looking self-assessment by those collaborative national program boards. So it looks forward to the end of the program. Will the program deliver the objectives that it originally set out within the life of the program, which sometimes is years into the future? And it's a useful tool because we need to reflect on that. Program boards need to reflect on that. And one of the things we'll be doing over the next quarter is leading program boards through a reprioritization and allocation of resources. And in some cases, that will lead to a rebased program plan. And then they will self-assess against that rebased program plan rather than the original one. And that is good industry standard program discipline. That's how programs are conventionally managed. And we need to go through that with all the robustness and transparency of governance and the assurance and the oversight that we've put in place over the last 6 months. In the deck, I've also included, or the team have also included, and I should pay credit to the team for the work that's been done in putting this and the program teams, a DHCW retrospective assessment of delivery in 23-24. So this is quite a different thing. Not using RAGs on this, because this would confuse if we're using RAG ratings in two different ways in the same report. But this asks a different question, which is, how has program delivery gone over the last year? What's our narrative, a view of how that has gone? And I think there's much more positive news in this. And I want to caution, right, that this is not DHCW trying to sugarcoat the pill. We've got big challenges collectively as an NHS Wales system about how we deliver our national digital programs effectively in the current environment that we have. But still, we mustn't lose sight of the fact that there is some real achievement over the last 12 months across the portfolio of programs. I'll just pick out a few of those. They're in the deck, but the NDR platform went live at the end of August last summer, and we've got reference and terminology, and some of the core services are available now in the NDR platform. That enables us to start moving data at scale, analytics and operational data into the NDR platform. The NHS Wales app was launched in the app stores on the 17th of April last year, 2023, and is, I think, about 180,000 or more users as of now, and is running 60,000 prescriptions a month through the NHS Wales app. So that is rapid delivery and impressive delivery for the NHS Wales app, and I'm very pleased that we just noted the business case for the next phase that came through. Medicines, big flagship program for medicines, the EPMA local procurements by each health board. They've all progressed and completed the procurement phase or the procurement process. Some health boards still to formally award contract, but that procurement phase has been done for all of the health boards in the year as planned. And the medicines EPS service, which is the primary care electronic transfer prescriptions, a technical proof of concept, a service proof of concept, the first live demonstrations, and we now have practices in North Wales that are using digital prescriptions end to end for the first time in Wales. And then for the WICIS program, which again we'll probably talk about in the report, the suppliers delivered the release candidate on time, so completed their software development work against the specification that they were provided with, and has done that on time during the year. I also want to pick out a few of the programs that were transferred to DHCW. So we don't originate all of these programs. Many programs that we deliver have been designed and initiated by others, and they come across to us. The two big ones, and again, this is on the agenda today, the LIMS program, the Laboratory Information Management System, previously known as LINC, has been extensively re-engineered during the year. So there's been a change of commercial partner, a change of the governance, an organizational change program for the program team, and close working with health boards all the way up to their board level on implementation timetables in order to meet the timetable that we now have because of those changes following the transfer of the program to us. The RISP program, similarly, the pathology and radiology imaging program, re-engineered, revised governance, revised team structures, new implementation timetable, very, very close working with health boards in real detail in order to stay on it and learn the lessons of things that come to us and things that run into trouble. And then the iCare program transitioned to us as a program from Cardiff and Vale as an extensive due diligence by ourselves and also by external audit agencies and others across the system in NHS Wales to really go through that program to understand. So I think there's a discipline, there's quite a lot to reflect on. And so finally, I'll just wrap up. So Welsh Government changed the governance for programs last autumn. We changed our arrangements last autumn as well in order to try to make our program and portfolio management more robust. This program delivery committee, underneath it, a portfolio management board and a portfolio management office that runs that to drive more consistency across programs. We're trying to move towards industry standard approaches, and we're also working hard on our transparency and reporting, and that inevitably brings out lots of issues, which is what you are seeing in front of you today, and so is everybody else who is watching this meeting. That's the nature of public transparency, and that's what we're committed to do. And I think that transparency is really important because this is not an in-house DHCW portfolio programs. These are national programs that we manage on behalf of NHS Wales and on behalf of Welsh Government. They're collective endeavours. They're driven by consent and representation, and we all across NHS Wales and wider into social care, if you look at the Connecting Care and WCCIS programmes, we are all in this together. And it is really important that we put out into the public domain as transparently as we can the status of these programmes and our analysis of why it is that they're in the position that they're in. So I know that's more detailed than I usually do in the introduction, but this is a year end. And I think it's really the first time that we can demonstrate the real maturity of the oversight and assurance arrangements that we have. And I'll stop and then take questions and comments on the rest of the slide deck. And you'll note particularly that there are 4 escalations for us to discuss as well. But if I hand back to you, David, and then if you can guide us through the rest of the agenda item.
Okay, cool. Anybody got any questions for Ivan based on his summary? Ruth.
Thanks, Ivan. I think that was really helpful, and it's really helpful to see this laid out like this. It gives me confidence that we are moving forwards into that next stage of maturity, and the transparency piece is really key because it's been quite difficult for us as a board to get a sense of, we know things are difficult, but now we can really see how difficult things are. And I think I'd refer to the kind of the next stage of evolution of the portfolio. And you referred to the rebaselining that will need to happen on some of these projects. So I just wondered when we would be looking at getting a sense of how much of the portfolio will we be in a rebaselining position with, and how much of it will we be needing to take other decisions about.
I'll answer the question as they come up, David, unless you want to bundle them later on, depending on how many come through. It's the programme boards that decide. So the programme chair and the programme board owns the decision as to whether and when to rebase. I'm the lead executive, so there's a lead DHCW executive for each of these programmes under the new governance arrangements. And I've asked those programmes whether we can try to get through that so that we can come back with the rebased programme plans by the next meeting of this, so over a quarter. And the programme boards meet monthly usually, and there has been a lot of work on programme teams as a result of changes at the year end in terms of the funding in some programme teams in particular. So I'm hoping that between the May and the June meetings we'll be able to make progress in some of those programmes on an updated programme plan, which has been signed off by the board. But I want to emphasise it's not for me to sign off or to impose that, and give it to the board. The board has to own, the collective consensual board that we have has got to own the new programme plan, and then we'll assess against that programme plan. And I am trying to get them to, the timing of it is, I'm hoping that in the same meeting, a programme board will, in an early agenda item, sign off the new programme plan, and then will, in a later agenda item, self-assess RAG confidence and delivery confidence against the programme plan that they've just signed off. So that will compress it a little bit. And I'm hoping I'll have at least some of them to be able to come back to the next meeting of the PDC.
Okay. Thanks, Evan. Any more questions for Evan? I can't see any, Evan. I just add to that bit of conversation you've just had with
Marian's just...
oh, yeah. Okay, thank you for spotting that. Marian.
Diolch, Gadeirydd. Ag Marian Wyn Jones dwi'n aelod annibynnol o'r pwyllgor yma ac o Iechyd a Gofal Digidol Cymru. Ifan, diolch am y cyflwyniad cynhwysfawr. Thank you so much for that very, very clear analysis of where we are. It does make some sobering reflection, actually, looking at the RAG ratings. We're all aware of the very challenging financial landscape facing NHS Wales and Welsh Government, and this is reflected very, very clearly in the dashboard you've so helpfully provided to the committee. Can you give us a sense of how long we might have to wait to get clarity in terms of funding on some of the individual programmes? There is a great deal of interdependency, I'm sure, in terms of the financial availability of resources, but it would be helpful to get your sense of how long we are likely to have to go at risk with some of these programmes. Diolch.
Diolch, Marian, thanks. Well, just to help people who are observing, so there are two stages really to the way that funding is allocated by Welsh Government. I said Welsh Government signs off on the business cases and then provides funding letters to each of these programmes, and we report on behalf of the programme, or the programme board signs off actually on the returns that go to Welsh Government on a quarterly basis. There have been some changes at the year end in those. We're currently operating under, we work very closely with Welsh Government, as you can imagine, especially when things are moving quickly, as they have been over the last 2 months. So we're working to a control total, which is a total sum across all of the DPIF programs, or the Digital Priorities Investment Fund programs that we have, that we manage on behalf of Welsh Government and wider NHS system. And we're working to a control total of £28 million on all of that. And within that, there is a set of funding assumptions. That is, there's a draft allocation of funding, technically draft, right? Although we're not expecting it to move, and each of the programs is working to that funding assumption. But the element of running at risk is that when those numbers are finally locked down, and they need to be locked down through the processes that Welsh Government runs internally, including ministerial advice and sign-off and all sorts of other assurance and scrutiny that they do within Welsh Government, which I'm familiar with, having worked there in the past, but I'm not involved with and not cited on because now I work for DHCW. Funding letters will then follow to us that formally confirm those they document the funding allocation. So we're waiting on those. So we are therefore working on a set of assumptions. That funding assumptions is a term that we're using with Welsh Government. So technically we're anticipating that funding, even though in some cases we're already into the year. So for the NDR and for the cancer programme, for example, which we might cover in the escalations later on, we're currently operating without a formal funding letter. But that doesn't mean that we're operating completely in the dark or that we're making stuff up. Clearly we're in dialogue with Welsh Government. So there is a degree of risk there, of course, but we're trying to manage that sensibly by having very close relationships and discussions continually with Welsh Government so that everybody understands what it is that we're aiming for.
Okay, great. Thanks, Evan. I was just going to reinforce the point you made about industry backpacks. My career has been in the private sector, and when circumstances change, particularly budgets are cut, there is a rebaselining of the project against the revised budget, and that's what we measure against. I understand the complexities of the arrangements we've got and why that's taking time, but I just think it's important to make that point because we are looking at quite a lot of red and amber on the dashboard, and a lot of it is because we're measuring against the baseline that went before us rather than looking at a re-baseline project. So I think we've covered that enough, but just wanted to be clear about that. So I'll hand back to you, Evan, and if you could just basically take us through the rest of the report. Assume that we as a committee have seen the report, so pull out the things that you think are important for us or that are risks, and then move on to the escalations, if you would, please.
Yes, thanks. So I'll start with the escalations. So again, just to rehearse the way that the governance works, program boards manage their own programs. They have oversight and assurance within the program domain. They will manage their own risk registers and all sorts of other controls. If program boards escalate, they will escalate to the DHCW Portfolio Management Board, which is an internal management board which operates at the portfolio level. So it doesn't manage the individual programs, but it does clearly manage escalations to it from individual programs. And usually those escalations would be, or typically, they would be things that can't be resolved within the program scope itself because they're to do with their multi-program impacts, or they're about inter-program dependencies or other pressures. The Programs Management Board can then escalate certain of those escalations that it receives to this Programs Delivery Committee, and it does that on the basis of alerting or advising, or I can never remember the last one, accept or authorize. It's an A anyway. And so there are 4 items that have been escalated to this Programs Delivery Committee from our Portfolio Management Board to make the Program Delivery Committee aware, really. So they're alert and advise, and they cover some of those things that we've just rehearsed, actually, coming to Marion's questions particularly. So 3 of them are to do with the funding position. So there was a degree of uncertainty at the last program board. The Programs Management Board had escalated a concern around the cancer funding because we didn't have confirmation of cancer funding. So that cancer funding escalation has now been closed because it's been included within the wider funding pressures across the delivery portfolio. That there is the 2.7 million request for funding for cancer is included in the funding assumption. So there is a funding assumption of 2.7 million, but the letter is not followed. So technically, as we discussed just earlier, a bit from Marion's question, the other thing which is here is an advisory one about the appointment of program chairs. So the program chairs, or technically they're called program oversight chairs, to each DPIF funded program is appointed by the Welsh Government. And there are a number of programs currently that don't have appointed program chairs, or who might need successors. But let's focus particularly on the ones that don't have program chairs at the moment. So the Welsh Intensive Care Information System doesn't have a program chair at the moment. iCare, Connecting Care, there's no program chair in place. And so we're running the governance, we're running the program board on an interim basis. And we've been through this before. So they did the DSPP, the NHS Wales app program board went through a period without a program chair. And what happened, I chaired those program boards then on an interim basis. But we're really trying to minimize those, working again with Welsh Government to protect the important role of a program oversight chair, the degree of independence. They've got a direct line of communication and responsibility to Mike Emery, the Director of Digital inside Welsh Government. So there is a risk there in that a key and important part of the programme governance is currently missing. And again, this requires Welsh Government to identify a programme chair and then to appoint by letter that individual, well, and for that individual to accept the appointment, I guess, technically. And then we'll be able to get back to a full complement of program chairs. So those are the 2 things that are escalated here. One is to do with the funding environment, and the second is the appointment of program chairs to all programs, because they're not all there at the moment.
Okay. Any questions on those, Ruth?
Thanks, Ivan. I just want to reiterate the point around the program chair availability. I mean, I think we focus a lot naturally on the funding and the issues with funding across the system, but I think the availability of program chairs and the right program chairs for us, it just goes to illustrate the stretch that there is on resource across the system at the moment. And I think it's a massive delivery risk for us not to have the right program chair in those programs. And I think we have seen across a number of probably the long running programs that we have taken on where we haven't had necessarily consistent governance in place, or there hasn't been somebody in that lead program chair role, or all of those problems, that increases the delivery risks significantly. So I don't want us to just concentrate on the funding. I think we really should just reiterate the point around getting those program chairs in place is a key priority.
Chris.
Yeah, thank you, Chair. And just Chris Darling, Board Secretary at DHCW, just to build on Ruth's point, I think the programme governance review and changes that have taken place that Ivan referred to in the autumn, one of the key aspects of that, one of the changes was the introduction of programme oversight chairs to give a level of independence, to give a system-wide view that sit outside of DHCW. So whilst the review was clear around accountability for delivery sitting within DHCW, those programme oversight chairs do play a key role and give us that level of independence.
Yes, thank you, Chris. Marion.
Thank you, Chair. Just again, building on both comments from Chris and Ruth. I think it is disappointing that we're in this position. We know from historical experience how important these roles are, and I think given that we've already got an escalation noted here formally in our papers, but I would like to urge that we need to send a very clear message about the importance of pursuing the appointment of these programme chairs as a matter of urgency. I don't think we can afford to rest on our laurels, and whilst it is not within our gift to make the appointment, I think we can reiterate the message that we are looking to see those appointments being expedited with urgency.
Yeah, can I just assure members that we are working closely with Welsh Government? So one of the things coming up, and I'm not sure of the exact date, is because the whole programme chairs arrangement is settling down as well. It is around 5 months old, I think, something like that. So I think it's within the next 4 to 5 weeks. In any case, we're having the first network meeting of all of the appointed programme chairs in order to bring them all together to do, and there's a combination of things. There's intended for that work, which is to review how it's gone over the last few months, to ensure that everybody's got consistent understanding of what the role is, to just consider whether there's anything which needs to be tweaked or adjusted to the role profile. So Chris and I for DHCW will be involved in that, possibly some of the other lead directors as well. And Mike Emery, I think, will also be joining that meeting. And obviously the first thing you need to do for that is to have a list of who you're going to invite. And in that list at the minute, there are some gaps. So we're working with Welsh Government to complete that list so that even if they're chairs designate, they would be able to join that meeting in order to help them with their onboarding, in order to help them to get into that role. So we are working. We're working. I think constructively with Welsh Government, just to give members that reassurance. So, we're escalating to and advise to make sure the board is aware of the situation.
Okay, thanks for that clarification, Even. Just for the sake of further clarity, is there one individual in Welsh Government that's responsible for appointing these chairs, or is it a number of people involved in the process?
Well, there'll be several involved in the process. The appointments are technically they're made by Mike Emery, the Director of Digital and Chief Digital Officer in the NHS Executive. Okay, cool. Fine. Okay, back to you, Ian. Great, thank you. So we'll go to the report now. So there's a slide. There's one slide. So these are assurance highlight reports for each of the major programs, which I think are fairly familiar now to members, because we've stabilised this. We've sort of we've stepped into this arrangement over the last couple of meetings, and we're trying to stabilise the dashboard so they become familiar, and therefore it's easier to use them. I'll go through each one. I'll just give a brief introduction. There will be so some of them will be for Sam, for example, to lead on if there are questions, rather than for myself. The thing that I want to emphasise is that these are assurance highlight reports to the end of 23-24, so to the end of March, because there's a delay between the program board obviously signing off their report and then that getting into the papers for this meeting. So they're not to the end of April, which is only 2 weeks ago. They're to the end of March. And that again, I think, is what we will see in each quarter, that there's an inevitable delay because of the timing of when program boards meet and when they sign off. And these are approved by the program boards, and then we are presenting them back to you. So I guess the most sensible way, as we usually do, is to go through each slide one at a time. I'll give a quick introduction and then ask for questions. The RAG ratings clearly are consistent with what's in the dashboard, so you'll get a sense of, and they use the same domains, etc. And then there's more narrative description about a kind of a 6 to 12 months look back and then a 6 to 12 months look forward in the main body of the report. And I think they pack in quite a lot of information, obviously. They've not got a forward look on their finances. So the finances that you will see in these slides are the 23-24 funding position, not the forward funding position, looking ahead into the next year or two. So the first of these is the National Data Resource. Obviously a very important program with which you're familiar, David, you especially, because I know you've taken a great deal of interest in the National Data Resource. I think on the basis that everybody's read them, so I think as do the others, it gives a good account of what's happened over the last 12 months or so, and then it looks forward. We are really trying to sharpen up what we will deliver over the next 12 months. I'm really, really keen, and I'm working closely with the program chair, John Peters, and with Rebecca as the program director, to think carefully about how we demonstrate the value and the impact of the services that we can now provide on the new NDR data platform. So that I know there's work proceeding with the data warehouse. This is the information services team, which is led by Rachel Powell in DHCW, to migrate the data analytics platforms onto the NDR platforms. But we're also looking at the direct care data in order to bring some of those things forward, because within the next 6 months or so, the NDR program is going to need to put together a new funding business case. It works on a 2-year funding business case cycle. So the phase 3 business case, which went to the main board about 1.25 years ago, only covers 23, 24, and 25, 26. And 24, 25, which means that sometime this calendar year, we need to get a new business case in place for funding beyond March of next year. So I think that is a really important part of the work for the NDR. And I'm really keen that before we do that, we can really demonstrate and describe impactful benefits that people really notice. Obviously the business case needs to include benefits forecast and assessments and reporting, but I want that we can show some things where people can really start to sense that they are feeling what the NDR is providing for them as a really important flagship program. So I'll pause there and see if anybody's got any questions or comments.
I can't see any comments or questions. Even I did have one, which was there was a report done on our benefits realization framework and the reference to the need to develop the toolkit. Is that something given what you said about benefits realization on NDR, is that something that's going to be used in anger on NDR soon?
Well, we want to use it on all programs, and NDR and medicines particularly have worked on their benefits forecasting. So I think the emphasis of the work that we've done over the last 12 to 18 months, including with the All Wales Benefits Group, and Claire Osmondson-Little, our finance director, has been leading on a lot of this work, and her team has been on a benefits framework and benefits registers. A benefits register being a list of the benefits that it is anticipated that each program will deliver. Some of our programs didn't have a traditional business case when they were first initiated. So medicines, for example, didn't have a traditional business case, a SOC or an FBC, and therefore had not done a full benefits forecast. It had a benefits framework, it had a benefits register, but in somewhat simplified terms, the programs deliver outcomes and then outcomes deliver benefits. So the medicines program's view was, well, we will deliver the outcomes and then we'll start tracking the benefits against the benefits register we've got. We don't need to do the forecasting because we've already got the funding confirmed. So we've gone back, we've done some initial work, or I wouldn't call it initial actually, we've done some first pass work to turn the benefits register from medicines into a benefits forecasting with more rigor around the models that we're using for each of the benefit types. How do we go from data sources, ideally routinely collected ones, to reportable benefits? And we want to do that across all of the programs and do that in as consistent a way as possible. There are lots and lots and lots and lots of benefits on the benefits register. There's a consolidated spreadsheet of all of the benefits for all of the programs. It's hundreds of rows and lots of very sensible, descriptive benefits, reduced harm, improved quality, better safety, fewer incidents. But it is difficult to aggregate those up into, well, what's the sum total? Because they tend towards the qualitative and the narrative sort of description of benefits. So the work we're going to do over the next 3 to 6 months is going to be turning those into metrics, as in numbers, quantifiable, that we can aggregate and sum and show our workings, etc. And yes, certainly the NDR will be part of that. And actually, I'll just comment. I can see Matt is on the screen. The DSPP business case has been through a degree of that process. So when it came to the program board and to the portfolio management board in January, there was an ask for more numbers in the benefits, if you like, showing the workings. And what's in the papers today shows the evidence of that. That work has been done additional, not just to describe the benefits, but to seek to quantify them. And so we want to bring more of that discipline into all of the programs.
Great, that's helpful. Marion, you got a question?
Yeah, just an observation first. Really welcome the work on the benefits realisation. It's really positive to see that work evolving and maturing. My question is around resources again, and you mention in the highlight report that vacancies and absence are continuing to constrain capacity, and because of the level of financial uncertainty, some of those posts that we are able to appoint to our fixed term only. Can you just elaborate a little bit to get a better understanding in terms of what impact this is having on the overall progress of the programme?
Yeah, absolutely. Probably the most straightforward way that we can manage changes in funding, whether that is in year or just ahead of the financial year, is to freeze our recruitment. And that's especially true of programs that are in that in their plan intend to accelerate and scale up. So the NDR program, for example, intended to accelerate and scale up certain activities once the platform was live. So you design and you build and you engineer, and then you deploy the platform, and then you scale up the activities that fill that platform with data. Medicines, similarly, you do your technical and proof of concept and your service proof of concept for EPS, and then you scale up the team that is going to roll out that EPS because you've now got a robust product. And when the money is less than was originally planned for in your implementation plan, it is very, what you don't want to do is to let go of your existing staff because they're already on fixed term or permanent contracts. So what you do is you delay or you pause the additional staff that you are going to bring forward. That's how you cope. And we have been using that mechanism through several programs, including in 23-24, because there were some in-year savings reductions that we were asked to provide to Welsh Government, and some of those were in the NDR programme. And the impact of that is we've been through a process in April to help Welsh Government with the Welsh Government Digital Policy Team to describe the impact of the funding reductions on two things, right? So we've described what's the impact on what's the delivery impact. What that means is all of the milestones, and again, members will be familiar with the way that we manage milestones across DHCW. There's a high degree of structure and method around the way that we deliver milestones. So the programs that have been affected by the funding reductions have identified all the milestones that they have, and they've assessed each milestone as to whether that will have to be rescoped or delayed as a result of the reduction in resources that we have available to us. And so you will see that some milestones are protected and don't slip at all, but others might slip by a quarter or by 2 quarters. And then subsequent to that, what then is the impact on the benefits that the program is intended to deliver? And in a really simplified way, if you think that when the program is complete, you will deliver £10 million of cash releasing equivalent, or time releasing or cash equivalent benefits, and the program's completion is delayed by a year, then you've missed out. on 10 million in benefits, right? Because they arrived a year later than they would otherwise have arrived. And so you can make an estimate or an indicative forecast, I suppose, of the benefits impact of the slippage in delivery. So that's the mechanism that we've been working with Welsh Government. There's more to it than that, because at the programme boards, particularly for the two programmes that have been most impacted by funding reductions, which is medicines and the NDR, the discussions at those programme boards, and there are several medicines programme boards this week where we're having these discussions, is how can we reallocate resources within the programme in order to protect the things that are most important, and the things that are most important are the ones that deliver greatest value and greatest benefit. Now, it's not quite as simple as saying, well, I need 10 heads over there, so I'll take 10 from here and move them, because often the roles, the skill mix doesn't fit. But that's what we're aiming to do within those programs, and ultimately within other programs as well, is to move our resources to where we need them, or where they can deliver the most value, in order to protect as much benefit as we can within the program. So this is, there's a really dynamic effort going on at the minute. The program teams are leading this work, but whatever they come up with will need to be endorsed and approved by the program board, which includes local partners, local delivery partners, local health boards, as well as ourselves. So again, it's not up to us simply to say, well, this is what we're going to do, and that's that. That needs to go through the assurance and the approvals in each of the program boards. And some of these programs are, there's a particularly the NDR actually, it's of all of our programs, it's probably the most federated, the most collaboratively consensual, with a very strong health board representation, and a significant amount. So if you look at the budget figures that we have for last year, 2.5 million of that, 2.8 million in the original plan, goes out to the health boards to support their work on local data resources, and that also is in the scope, obviously, of the reprofiling. The reductions can't impact only the core national team; they have to impact the whole program, and that means reductions in the funding allocated to local health boards, as well as reductions in the central national team. So these are difficult, they're difficult conversations.
Okay, thanks, Stephen. To move on to the next programme, please.
I'm going to shut up for a while now, and I'm going to hand over to Sam Hall, because the next one is the Welsh Community Care Information System, WCCIS.
Hello, thank you. Yeah, so WCCIS, I think everything that we've already talked about is also reflective of this programme as well. I think there's a couple of things to call out for this especially, and I think it's really easy to lose sight of the fact that the Connecting Care programme has been kind of set up, established, done all the groundwork with zero funding. We are currently running the WCCIS programme and the services associated with that, and the supplier management and the partnership management, and with local authorities and health boards as part of that programme. And alongside that, we've established the Connecting Care programme. And so, where you see amber red, I am really confident that is there because we are doing a job and a half, frankly. And that is to the credit of the teams that have been doing that. And so, that's all been done since last summer. And I think we're in a really quite a strong position now with the work that's been done. There's still a lot of work we still have to do. And we've been asked by Welsh Government to produce quite a comprehensive business case now for Connecting Care. But actually the engagement done with local authorities, with suppliers, with health boards has started to really kind of crystallise that programme going forward. But as with other programmes, there is no commitment of funding for this year or for further years. And as you know, this programme it's not a flash in the pan. It's going to take several years to deliver the benefits and to actually roll out, to procure and roll out and implement replacements for the current product, which is going to be going out of service. So there is an imperative on time. We're trying to get as much time as we can out of the existing system to buy us the time with our partners to do this properly. And I think it's worth us, again, some of you will predate me by quite a while, but will be aware of the issues we had around the WCCIS programme and the fact that it was less than successful with the partners, in that it had lots of performance issues and usability issues. So I think the team have done an amazing job to keep it running and to kind of really calm down some of the noise in the system around this. However, we have to absolutely make sure that whatever we replace this with in the future is the best we can do for our practitioners and our patients. So we've got a very clear steer. We're really understand the scope very strongly around this. And so where we are now is we've brought in some people to support us with completing that full business case. Although it's not at the normal time you would expect a full business case to be produced, because we haven't gone to procurement, because we can't, because we have no funding agreed. But we're getting as close as we can to that kind of investment proposal. And we've also added into we've added more completely into the programme the mental health functionality, which was something which was a bit of a periphery when we started planning, but is absolutely so desperately needed across Wales. And we're working with partners and including mental health into that space. And we also have, as part of this, in the last year, completed discovery, 2 phases of discovery around mental health, which is now being used to inform what we need for the future. So whilst digital is one element of it, other parts of that discovery showed where service improvements could be made and processes need to change. And we've worked with the strategic programme for mental health, which has just been set up by the NHS exec. And we met with them only yesterday to talk about their ownership now of the outcome of that discovery. So this isn't just about it's not just about the technology, it's about the digital application of the tools. And I think it's an ambitious programme for the future, and I think we're in a much better position than we were even maybe 3 or 4 months ago. But funding will continue to be an issue until we understand the way forward.
Okay, thank you, Sam, for that summary. Anybody got any questions for Sam? Can't see any hands, so I have got one, Sam. So as part of the work that you've done, we've got WCIS, which will eventually go out of service because it'll be beyond its life and the vendor won't support it, or they'll support it at significantly extra cost. Have we laid out the timeline for WCIS and the replacement Connecting Care? And having done that, do we understand what the window is for sort of getting the funding agreed so that we can commence the Connecting Care programme?
Yes, we've done loads of work actually around the timeline and critical pathways for that. Obviously, it will be dependent on funding. The longer it takes to get the funding, obviously that window starts to shorten, which is obviously of a concern. But one of the big elements we want to make sure we can do is to if we can lengthen any of the time around it's actually the social care element which comes to an end sooner than anything else. So we want to lengthen that as much as possible. So we're working to try and create a coterminous date for contracts. As you know, there's a master service agreement. Everyone took it at different times. We're trying to bring that together so we actually have dates to aim for, as opposed to potentially 20 different dates to aim to.
Fine. Okay, good luck with that one, Sam. Okay. Unless there's any more questions for Sam, I'll thank you, Sam, for that update, and hand back to Evan.
Great, thank you very much, Chair. So next one is the Digital Maternity Programme, or Digital Maternity Cymru. This comes up and is reported as being extremely red, and I'm just going to sort of set some of the background and the context here, because I think it's a lesson of how we are it's an example of how we're trying to apply lessons learned. And it's also an example of a programme which is self-assessing its delivery confidence against its original programme plan, when in fact there have been some significant changes to the way that the programme is being conceived of and designed. So the Welsh Government awarded funding for digital maternity around about 2 years ago, basically to absolutely crash on with procurement. And the objective of the programme is a digital maternity solution across Wales. One digital maternity solution across the whole of Wales, strongly supported by the maternity and the midwife clinical community. And we took a pause in the autumn of last year, reflecting on the lessons that we were learning from several other programs around the need for more structure around the approval of business cases. So there would be no OBC and no FBC in that process prior to procurement, for example. So the decision was there was a discovery exercise, but no formal OBC. So there was no collective approval of an OBC, no specific approval of by Welsh Government or by the collaborative board, etc. So we took a pause and we're developing an outline business case which sets out various options. And as part of that, that's also enabled us to seek to confirm Health Board's intention to adopt to adopt a single maternity system across Wales. And one Health Board has already said, well, we're not going to do that. We've already got one of our own. So you can view that as, well, that's exactly why we needed an OBC, because otherwise we were progressing with the program on ill-founded assumptions. But that also has caused some considerations as to, well, what then is the most effective way of delivering. So as well as the OBC, the second key decision or the key choice is about the funding of the local implementation. So the original assumption was that each health board would fund their local assumption when it came time to do that a couple of years down the line. In fact, in the original program plan this year, so 24-25 was, so the original plan was that the procurement would have been completed around about now, and then we'd be moving into a customization configuration exercise, and then sometime within about a year or so, health boards would start to implement, and they'd be paying for that themselves. However, lessons learned are that when it comes to the choice, there is lots of pressure out there in the health board environment, and additional funding is often required. And local implementations can be conditional on additional funding being provided by Welsh Government. We're seeing that in EPMA, for example. So each health board is putting a business case to Welsh Government for the local EPMA implementation costs. So that's not running through the national programme. The programme that we manage is the central coordinating programme for EPMA. Each health board is putting in their own bid for that, which I'll just summarise later when we get to that slide. So there is both a requirement for an OBC prior to starting the procurement in order to ensure that we've got sign up. There's also in that OBC a switch from local funding to central funding, because that will take some of the friction away and it will give more delivery confidence, because if you know that you've got the funding from Welsh Government, then you can make firmer assumptions about your ability to deliver to timetable, because you're not reliant on all the different parties being able and willing to find the money that they need when they need it, in the midst of all the other pressures that they are facing. So that's causing some delays, of course, because in the way that OBCs and FBCs work, you need approval on the outline business case. And I think ideally we would also look for a really cast iron commitment from health boards on the implementation timetable and their willingness and intent to implement. Again, historically in programs, we've assumed that, or there's been an assumption that if there's a representative program board, which includes health board representation, and that health board representation has endorsed collectively the outline business case, that constitutes a commitment to implement. But it turns out that sometimes, under the pressure of circumstances and context, that it doesn't. And so again, we're trying to apply our lessons learned to say, well, how can we create as much certainty for the delivery of this program as is possible? And that obviously has a very significant impact then on the timetable, because we've not started the procurement process. And in the original plan, we'd be coming to the end of it, or would have just about be completing it right now. So the assessment is still against the original program timeline and original program plan. So it's extremely red. I want to give this program, the delivery committee, my view, stroke my assurance that I think the program board is doing the right thing. Based on the experience of other programs over the last 12 to 18 months, it's doing the right thing to try to lock down the approvals and the commitments that are needed on implementation in order to provide as much uncertainty and reduce assumptions and turn them into commitments, because that investment now will ensure that we've got a much firmer roadmap for the actual delivery of the program, which will give everybody more delivery confidence as we run through that program. But it requires quite a significant reset. So and it's the OBC that resets the program plan, which is part of the challenge, isn't it, right? Because it's the approval of the OBC that will create the new program plan against which to assess, and it would almost be, it's not adding a lot of value to go back to revise the old program plan when you know that there's an OBC which is just which is just about to be submitted. So I think that's the context for Digital Maternity Cymru. In that sense, it's in a pre-program phase, so it's still in the OBC development phase. It's a kind of like a project leading in, and that's because of a change of posture, which is a response to the lessons that we learnt. That have been learnt last year. But of course, the OBC and the change of decision has all been approved through the programme board. It's not a unilateral decision by DHW. It's a collective decision through the programme board.
Yeah. Okay, thanks for that summary, Ian. Any questions on Digital Maternity Cymru? No, that wasn't very clear, even. Just doing a quick time check, we've got probably 17, a little bit more minutes left of this part of the agenda, and we've got 8 programs to go through. You provide in excellent detail, but I think if we do that for all of them, we're going to run over massively. So we can either do it very quickly, but I think I'd prefer you to pick up the ones that are more important in terms of this committee and focus on a subset of what's remaining in the pack.
Certainly. Well, so some of these we can speed up significantly on.
Okay.
I think it's worth. I'm just looking at Sam on my screen. I think it's worth dwelling on iCare briefly. Sorry, I think that's an important one to cover. And I'll just look ahead. So on PAS, I'll give a very brief summary. Sam Lloyd has given his apologies, so he's not able to join us. I'll ask Michelle to give a brief update on the Welsh Intensive Care Information System and where we are on that. The next two, RISP and LIMS. We've got a further item on, so I think we can take most of that in that one. And then medicines, I'll just give an update on medicines because it's just been through an important transition in terms of the way that it manages that portfolio. And then we'll come to cancer, and I've got Matt on, so I want to give Matt a moment on DSPP as well, since he's been on the call and we'll be through. So we'll try and do that as quickly as we can. Does that sound okay? Yeah. So Sam, iCare first.
Thanks, Ivan. Yeah, okay, I will be as brief as I can. So, as you know, this programme started transitioning to us through last year from Cardiff and Vale. We have actually, it might have been earlier this year now, we had an internal audit to give us assurance that we were doing very, due diligence on moving this across, and the governance required to set it up and to kind of take it forward in the way that we would hope, and that a program could really get to grips with. That's included things like reviewing who is on that program board. When we brought it across, it had 88, I think it was 88 members, which of course is really difficult to get any kind of consensus and decision making. And so we've done some work around that. As we've already discussed today, we don't have a program chair. So this and Connecting Care does not have a program chair, which is something we really need to get sorted as quickly as possible. And where we are now, with all of the work that has been done over the last few months, we've got a request from Welsh Government colleagues to put a day zero plan in for iCare by the 14th of June. So we are working headlong on getting that information together for them, with a view for them to make a decision on ongoing funding this year. At the moment we have, which is why we're very red, as other programmes are, just £300,000, which just about covers some of the basic programme work. And obviously there's a lot more work that goes on in a programme, and so we really need to understand the funding going forward for this programme.
I think that can be said of a number of programmes. Chris.
Thanks, Chair. Yeah, not to extend this item, but just to comment on, because the internal audit report was noted earlier, it was taken through the audit committee, and Marion, as Chair, asked for it to be on this committee for noting by committee members. I think it's just worth noting the outcome that, as Sam mentioned, the due diligence had taken place. However, even with that, the level of residual risk that we have inherited is high, extremely high, and that's mainly relating to the funding position. So I think I just wanted to make that point that the due diligence has been done. That doesn't mean it's not high risk.
Yes. Thank you, Chris. I'm sure Marion, who's got a hand up, is going to elaborate a little bit as well.
Thank you, Chair. I was just merely going to make reference to that internal audit. And just for the record, I think it's publicly worth noting in this committee that that audit did validate DHCW's comprehensive approach to the transfer. And these programme transfers are inherently very high risk, as we've debated and discussed previously. But I think it's worth noting that publicly at today's committee. Diolch.
Thanks, Marion. Evan, back to you then for Bridgen Paz.
Yep. So very briefly, so this is a very complex data mapping and migration. One health board system to another health board system. They both use Welsh PAS, which is a system that we provide, but Welsh PAS is locally configured. So the configurations are very, very different in Swansea Bay and in Cwmtawd Morgannwg. Princess of Wales Hospital moved, I think 5 years or 6 years ago, from one to the next, from one to the other. And the data systems, the data needs to move, the pathways need to move, and various other things. The two health boards are very strongly leading on this program. We're in a supporting mode. As I said, different programs, there's a self-assessment by the program, different programs RAG rate in different ways. I think that there'd be, well, I guess I would say, right, from my somewhat external view, that they're being quite harsh on themselves, right, to rate delivery confidence in this as read. It is a very complex, very difficult, challenging program, but there's good progress, which you can see in the report actually since the last report. And it feels as if, from a distance from me anyway, it feels as if it's under control with challenges to resolve, and that would be amber and amber red in general rather than red. So I think it's telegraphing a worse situation. But again, it is a self-assessment by the program board. So the program board has got to come to an assessment and then report them. And it's very important, I think, that we protect that. Okay.
No, thanks for that summary, Evan. I can't see any questions for you on Welsh PAS. So should we move on to WCIS next?
Great. I'm going to ask Michelle just to give an update on the WCIS program.
Okay.
Thank you, Evan. Brief introduction. Michelle Simon, Director of Programmes and Engagement for Digital Health and Care Wales. Critical care is one of the areas that I lead on with the team. So this report is obviously to the end of March. There's a lot of activity in relation to critical care at the moment. I just wanted to call out for the committee's awareness. So working with health boards led by the testing in Anira and Bevan, with other health boards now very much on board, we have come to a position where the solution as currently configured, designed and configured by stakeholders across Wales is not in a position where it can be rolled out. So we'd paused the rollout, and the conclusion from clinicians and other stakeholders is that further development work is required to simplify the workflows. So that's the position as is. We've been working through that with the supplier, who've been very helpful to us in working with us to understand what we need to do in order to achieve that. That will take time and funding in order to move that forward. We've also been in detailed discussions with the health boards at a senior level in terms of their participation in that and their commitment then to implement the solution and to meet the ongoing costs of running the solution within their own organisation. So that is very much underway, or discussion underway at the moment. We're also meeting with Welsh Government this week to talk about any implications arising from that. From that, we need to make some clear decisions then in terms of how we move forward with the critical care system. So happy to take any questions.
Okay, thanks, Michelle. Marion.
Thank you, Chair. You did say, Michelle, that this would take time and funding. Could you give us some indication of the window of opportunity that we have for final decision making?
Yes, thanks, Marion. So we need to make a decision on this fairly quickly, really, for two reasons. One, we're keen to move forward with the implementation, and we are effectively on pause at the moment while we make these key decisions. And two, because Digital Health and Care Wales holds a contract with the supplier who is meeting their commitments under the contract and is expecting us to move forward. And there are obviously financial and commercial implications in relation to that. I am really keen that we get to a position of a decision by the end of this month. That is quite ambitious, but I think we do need to move quickly for a number of reasons.
Yes. Okay, Michelle, I would agree with your assessment of where we are. I think time is now of the essence, so let's hope we can resolve this by end of the month or early June, and then press forward with the programme. Can't see any other hands, so back to you, even for digital medicines portfolio.
Thank you. So this should be the last time that we have one consolidated slide on the digital medicines transformation portfolio, which includes multiple programs, EPMA, EPS, e-prescribing and medicines administration, electronic prescription system, and the shared medicines record, and also the elements that are in the NHS Wales app access. Historically, these have been organised as a sub-portfolio. So there's a portfolio just of those 4 programs and projects, and that's what's being reported in this slide deck. From the 1st of April, that intermediate portfolio level has been dissolved or has gone, and the programs now escalate directly to the DHCW Portfolio Management Board. So we'll see those programs having a slide each, while for EPMA and for EPS, certainly the other 2 are smaller projects. So we'll think about how sensibly we can present those. The programs and the sub-portfolio, as it's reported here, I think is making very good progress. And we've really emphasised that in the transition from the previous arrangements to the new arrangements to try to reassure everybody in the team that the programmes continue exactly as the programmes delivered before. They're making good progress. And in fact, probably the biggest challenge for them, particularly in the EPS space, is what's going on in the wider primary care space with the exit of one of our key suppliers. There's a timetable which is imposed upon us by that, the speed at which the 2 suppliers can transition or migrate practices from one to the next. There is nothing that we can do to accelerate that. Well, we're trying to find ways that we can support the suppliers, but there's very little that we can do, and that is going to extend the program timeline for the EPS program in the medicines space, because of that supply dependency. There's also been a significant funding reduction in the funding assumptions that we're working to, and the program teams are working through that to minimize the impact of that by reallocating resources between those programs and in trying to protect as much value as possible. And there are several program boards coming up through the rest of this week. In fact, two of these programs are meeting tomorrow, so I've got a full day of attending medicines programs boards. But it's been a smooth transition, and I'm really pleased with the way that transition has gone. And this is a really, really important portfolio of programs that is a high-level ministerial priority for us. So it's the RAG rating is going to come under pressure as the budget impact bites as we head into 24-25. But hopefully we'll be able to manage that effectively across the 4 programs by taking the load in a sensible way.
Yeah. Okay, that sounds like a pragmatic approach. Any questions on digital medicines portfolio? No, I think you've covered that nicely, Ian. Thank you. So next one is cancer. Is that you?
Well, yeah, I'll give a brief update. Maybe Michelle will want to come in. David Sheard, who's recently retired, did a fantastic job, a great service to DHCW for many years. So I'll give him this acknowledgement in public. I'm very, very sorry to see David go, but very happy for him that he gets to enjoy retirement. So cancer, we have been dealing for many, many years with firstly the risks and then the consequences of the CANISC platform that we maintained well beyond end of life to such a degree that the code base on which it was built was poorly understood, and it was very hard for us to understand what was happening inside that code, inside that software solution. And as we stand down CANISC, what we're doing is we're recreating the functionality, the reports, the interfaces, and various other things in our core products, the Welsh Clinical Portal and the Welsh Patient Administration System, WPAS. It is difficult because teams are trying to reverse engineer a black box because CANISC was written 25 years ago, I think, in the late 1990s and early 2000s. And I think the key message is that we held on to it for far longer than we should have. And that legacy burden or that technical debt got bigger and bigger and bigger until eventually it was almost undigestible. So it is taking longer to unravel all of that and to rebuild that functionality and to recreate it in our other systems than was originally intended. There's a plan to resolve that. I think we discussed earlier about the funding requirement for 24-25. When that is formally confirmed to us by letter, we should have a new program plan. But again, these ratings, the overall RAG and the timeline, so there's kind of rule that if one of your domains is red, then ordinarily your overall should be red as well. So the timeline is clearly behind the original plan because the work we were aiming for it to be done in 23-24. So therefore the timeline is red, and it will continue to be red until the program plan is rebased against the revised funding that is received. So that's where the cancer informatics program is at the moment.
Right. And just for clarity, I think we covered this earlier. So the funding's been confirmed. We're just waiting on the letter. So that's the element of risk, and then we'll re-baseline.
Yeah. So we have within the control total that we've been given, we have a funding assumption for cancer. So there is an allocation to cancer, but that has not been formally documented through a funding letter, which is the governance mechanism that we use for each individual program. So that needs to follow, but we're working on the basis. It is technically an assumption, but we've got a high degree of confidence based on our conversations with Welsh Government that they will follow in due course.
Yeah. Okay. Thanks for that clarification. Any questions for even on cancer? I can't see anything, so I think we're over to Matt for the last item, which is DSPP.
Thanks, Chair. For DSPP, at the end of March position was we were amber green overall. We'd adopted all GP practices in Wales and achieved our target by the end of March, which was an important feat. And as Ivan described, at that time we had about 160,000 people who downloaded the app. As of today, it's just over 200,000, so progress continuing. Importantly, we were very much focused on a couple of key features. The most important of those to us is the Welsh Identity Verification Service, the feature which allows everybody to be able to access the NHS Wales app in Wales, particularly those who aren't able to use the current route enabled via NHS login in England. So we're planning for that to be in place, to be trialled in the next couple of weeks, and then for that to be available in June. In terms of on the right-hand side of the slide, our biggest challenge is really about the certainty over the future. The business case will answer some of that in terms of providing the means for Welsh Government to understand the investment we think is needed within the NHS Wales app, but also, and this is the important point, also what we will give, what we will deliver in return, because our work so far and our work in the period of January and March, particularly with the planned care programme, showed us that we can bring a really effective collaboration together, but at some point resource and money is often the key enabler that you need to have in place. So that discharge to us and prioritised for delivery will allow us to get on and really add functionality which people and the public in Wales want. So that's my summary of where DSPP is.
Okay, great. Thanks, Matt. Thanks for being summarising that nicely in a short period of time. Any questions on DSPP? Okay, Marion.
Very briefly, in the interest of time then, Chair, clearly funding is an absolute a crucial issue here. For the benefit of the committee, could you just remind us, putting you on the spot, and perhaps you won't have the figures to hand, but what level of investment has gone into the NHS Wales app to date? So what are we talking about up to this point? And it would give us some indication of the level of investment that we've seen in this particular development.
I can. So for benefit of everybody's awareness, broadly £30 million of funding has gone into the NHS Wales app to date, which allowed us to develop the app, allowed us to deploy the app, and importantly, allowed us to operate and maintain the app as a service in itself to support all of those people. The ask for the future, particularly for the future starting the 1st of April onwards, is for an enhanced level of investment on what we get on an annual basis. So broadly, we have a £6 million investment in the app this year. We're looking for just under £9 million of investment next year and the year afterwards, which allows us not only to maintain the core of the app, but also allows us to be able to extend and add functionality which is going to be of real value, and to do it in a really compressed period of time. And so that's the opportunity space which we're working with partners on at the moment. There you go. So I've alerted and caused lots of interest.
You have indeed, Matt. Ruth.
Thanks, David. Thanks, Matt, for that update. I've said it before on this call, and I'm glad our finance director isn't on here. But it's not just the money that's important with this programme. It's actually being able to prioritise out what we deliver and prioritise those benefits. And I think you've done that well in the business case for sustainable funding. But as we move forward, that prioritisation, I think, is going to be the key piece for us. There are lots of things we could deliver quickly that would bring benefit to people using this app. So, I think that the funding is the big issue, but actually underlying that, we need to be able to prioritise properly for this. Thank you.
Yes, I would agree with that, Ruth. Even.
Yeah, and I just want to try to put some of that in context. Comparisons are really, really difficult for the app. It's sort of seductively easy to say, well, let's compare per user. Let's compare Wales versus England. Let's compare on a population basis. But I think it's tough to do that because an app costs as much to deliver for 1 million people as it does for 10 million people or for 50 million people, really. In terms of the core technology platforms that you need and the resilience and the robustness and the cyber security and all the other things that you need around those features, there is a scale relevant to the numbers of users about some of your hosting costs and some of your support services, etc. England have stepped up their investment into the NHS app in England quite significantly recently, and this year they're putting £50 million into the NHS app in England. Now, clearly, we're never going to be able to compete with that, and we need to think about how do we get the right balance between the run cost and the development of new features in the app, and that's what the business case tries to set out: is how do we keep both of those going? So, apps in a health context, the NHS app and the NHS Wales app, they're really, really important tools. We're putting on about 1,000 people a day, 1,000 new users per day into the NHS Wales app. The more users, the more it becomes a really cost-efficient route to be reaching lots of patients and lots of the public for all sorts of different reasons. And so it is going to cost a significant amount. But I'm convinced that it's a sensible, worthwhile investment when you compare it to the other ways that we can reach those people. And also in the context of how modern digital technologies work and how much needs to be invested in them, especially if you want a really high quality product that is performant and secure.
Yeah, I think we'd all agree with that, Even. Okay, so many thanks, Matt. Even, is there anything in summary you want to say before we move on to look at the corporate risk register?
No, I think I've left only 3 minutes for the corporate risk register, so maybe that's a little bit tight. So I'll apologise to Chris and to you, Chair, but hopefully members have found it very useful to have that level of transparency and reporting and an open environment in which to ask questions, so that we can so that we can report on behalf of all of NHS Wales as to how these really, really important national digital transformation programmes are going at the moment. And there's lots to work on. But it is important that we don't try to pretend it isn't, that those challenges aren't there, that we bring them out into the open and then we resolve them collectively by working with all of our partners, suppliers and health boards and trusts.
Okay, great. Thanks again, Even, and thanks to everybody who's contributed to that session. Right, so we'll hand over to Chris Darling now to cover the corporate risk register. Chris, we are running slightly behind time, but if you need the 10 minutes, then please take it and we'll try and catch up a bit later.
Yeah, thank you, Chair. I will try and be as concise as possible. And the reason this item is always after the programme dashboard run through is because a number of the risks do get covered. So I won't reiterate where that has been the case. So we've, as committee members know, taken a committee assignment approach. So all major programme risks that are on the corporate risk register are coming here for oversight and scrutiny. So that includes programme specific risks, but also any portfolio level opportunities or threats that are identified. So just for context, there's 16 corporate risks, of which 5 are assigned to this committee. There was one that was considered earlier in private session, so I'm not going to go into that. So the 4 risks assigned to this committee, there's the switching service data warehouse, sustainable major programme fundings. And I think we've covered programme funding, but it's probably worth noting that as a portfolio level risk, given how frequently it's come up. And I know Ivan and Claire are meeting to run through the IMTP review on the 24th of May. So we should get a bit of an update from a funding perspective following that. Intensive care or the WICIS implementation delay, Michelle's updated and Marion asked a direct question around timeframe. So I think that's covered. And then the 4th one is the impact of the cost to the transition team. So the 2, David, I think it's worth just pausing on if even Ivan's able to, just to update on the switching service and the transition team update, or with Matt. I think those are the 2 that we haven't covered in any detail yet.
Yeah, agreed, Chris.
Yeah, so I'll cover those two briefly. So the switching service is a piece of legacy technology. It's about how we bring data into some of our systems. We use CSV files and then a whole series of checks to validate that data. It's a largely automated process, been very robust and resilient over the last 15 years or so. It's a manageable risk because if that automated process, it doesn't have a failover, so it's a single service. If it was to collapse, then we could replicate that all manually if we really needed to. However, that's not the long-term mitigation. The long-term mitigation is to get rid of the need for a switching service completely, and that is part of the data warehouse migration work into the NDR environment, technically into the National Data Analytics Platform environment. When that work is completed, then there won't be a need for a switching service because the new platform and the new technologies will take care of that. And I think that is a good ambition, to take away the need for a thing which is a little bit clunky and old. But so we're managing that risk, we're tolerating it effectively at the moment. But there is a resolution which is to get rid of that whole function. And then the impact of the cost of the transition team is in the NHS Wales app space. Matt might want to come in. I'll just give a quick summary, which it is, we have used external suppliers to provide our development capacity for the NHS Wales app. That has delivered good progress, good features, to time, to plan, as negotiated through 12-week work packages. And we've done an external audit of how the DSPP program runs and had a reasonable assurance on that. So there's a robust process, but it's not cheap. Right? We've made choices, and we're not unique in it. In that NHS England have outsourced the development of the NHS app to IBM, I believe. And so this is a standard model to outsource, but it is expensive, and so we want to bring that in-house to develop our own in-house teams and our own capability to do that. And we're aiming to do that this year. We're working very closely with the operations team in order to. There's a degree of knowledge transfer. There's a transfer of responsibility and accountability for the code base, and we want to be perfectly assured that we've got the capability and capacity that we need internally before we stand down our external supplier, because the app is shop window, mission critical, cannot go wrong. So we need a high level of confidence that we can take all of that strain internally before we start to wind down our external support. But it's something which I think is important for us to do. The impact is we've got a double run, therefore, for a period where we'll have both an internal team and an external team, and we want to minimize that period, but we don't want to jump into assumptions and then find that there's a problem there. So that's the risk that we're managing in this space.
Okay, thanks.
I can see Matt.
Yeah.
No, agree with Ivan totally. And it's one of the most active things we're working on at the moment, because we recognise that we only have a certain length development runway, with our existing suppliers, and we're trying to marry things up so that we can grow our internal team as part of a hybrid team, and at a particular point in time we know that they're going to be able to deliver for us. And so it's that confidence of knowing that they're going to be able to deliver for us on an enduring basis, which we want to be able to get to. If, of course, there's additional investment which comes in either later this year or into next year, with the business case, then we've got lots of opportunities with both our internal team, which we'll hope to have developed, but also our external team, so we can surge up, so to speak. But it's a really interesting thing and an exciting thing we're doing. We just want to make sure that before we step into it, we're going to be assured that we can get to the point we need to.
I fully agree with you, Matt. And the aspiration to bring that development in-house is absolutely the right one. But as Ivan said, we've got to do it in a carefully way so that we can maintain the level of program performance that we've had to date. So we'll keep an eye on that as we move forward. Chris, back to you. Is there anything you want to say in summary before we wrap up this particular bit of the session?
Thank you, Chair. Yeah, just to summarise, so the one new risk is that risk that Matt and Ivan have just described to the committee. So that's come on since the last committee meeting. There's been one change in risk score, which was the risk considered in private session earlier, slight increase in risk score. And there's one 0301 risk that was removed following the last committee meeting where it was considered. So those are the changes and those are the risks assigned to us. Thank you, Chair.
Thanks, Chris. Right, we're at the point where we're going to take a comfort break. We are 4 minutes over schedule, but I suggest we take the full 15 minutes and reconvene this meeting at 12:20. Could I remind everybody during the break just to turn your cameras off and make sure your mic is muted, and then we'll all rejoin at or around 11:20, sorry, 12:20. Cool. Thank you. My apologies if you joined at 1:15. We overran the morning session slightly, so we took our full 15 minutes and started a little bit later.
That's fine. Michelle did make me aware.
All right, great. Thank you, Michelle. Okay, I think we're good to start the afternoon session. Michelle, Alison, maybe you could introduce yourself once you've been brought into the conversation by Evan. We're now moving on to the annual assurance reports covering two of our major programmes. Evan, I think you're going to tee this up for us and then bring Alison in as required.
Thanks. Well, as required, I think I'll be bringing Alison in to handle nearly all of the next items, but I'll just preface those by saying at each of the programme's delivery committee meetings, we do an annual assurance report on a number of our major programmes. And I think that's important, and it's important both for the programmes to have an opportunity to give a more rounded picture than what is seen in the usual update slides, but also it's an opportunity for the delivery committee to be able to zoom out a little bit and look at how is the trajectory of delivery looking for that program and the wider delivery confidence. It's great to see both these two really important diagnostics programs coming together. There's a close alignment between them. Alison's the director for both of these programs. She's doing a very good job there. Earlier on in the meeting, in the previous part of the meeting, I talked about how much change and how much re-engineering of these programs was needed over the last 12 months or during the calendar year 2023. I'm sure you'll hear a little bit more about that. So there's a strong team on these programs. Myself, Michelle, Alison, the program teams work very closely together as part of the wider portfolio. But I'm really pleased that Alison's here to join, to be able to present, because so much of the credit is down to her. Yeah, we gave her a really, really tough job to do last year, and she's done a good job of it. So I'm going to hand over directly to Alison, I think, and then she's going to take us through the next 40 minutes or so, or 50 minutes, however long we have to do it. Thank you, Alison. Over to you.
Hi, good afternoon. So for those of you who don't know me, Alison Maguire, Programme Director for the Diagnostics. And thank you for those kind words. I would say it's always a team effort. I get an awful lot of support to deliver this, a lot of support. So I just want to make that clear. So I have got a set of slides, which I think you've all got. I'll just present them now if they come up, with my team's being a tad slow. Hopefully.
Got it now, Alison, thanks.
Are they okay?
Yeah.
Hopefully they're there. So yeah, just to recap, within my programme, there's some other little bits and bobs, as I call it, in the programme, but the two main ones are LIMS and RISP, which are the ones that we're focusing on today. I'm going to walk through LIMS first and then RISP. Just a couple of things on the RISP one, just to note that this is Philips' largest implementation across Europe for RISP. So a really large programme, RISP. And then LIMS, as we noted, we're in contingency plan, shortened timelines. So there's a lot to achieve in a short amount of time. And just in terms of a bit of a history on LIMS, as you know, it was started in 2017. There was an OBC. We had another supplier, Citadel Health. And then there were some challenges there, as we noted, and then the programme was moved over to DHCW in Jan, where we did a complete review. And as I think by the sounds that you've been told, we changed all the governance and simplified it. It was a very complex governance. We re-looked at the teams, and we restructured the teams to focus on the delivery. And then in July, the decision was taken to jointly end the contract with Citadel, and we evoked our contingency plan, which is with our existing supplier, InterSystems. Now, with that, again, our timelines went from 4 years to 2, so an awful lot to do. Now, having said that, although that's a lot to do, in some ways it does help focus people. So when you've got less time to do things and less time to think, then it really focuses people. And we put a lot of robust management in here. So in terms of when we've got decisions to make, because this is collaborative working, it's very challenging when you're trying to get all the health boards and trusts to agree. So we've taken very much a task and finish approach to anything that we do. So we ensure that people know decisions that need to be made, so the decision makers are in the room and they have all the right information so they can make those decisions quickly. So that's the approach we've taken. Now, it's so far, like I say, it's tight, but InterSystems, we delivered the first 2 commercial milestones on track. So we had the infrastructure set up by October. So that's the national infrastructure was there and we connected to it. By December, we had the base Wales system. So on that, we again connected to that. We had all our static data that we call it. And then in Jan, we started the actual build. So that's the configuration of the system. Now, that is a real challenge for us, the build. There's a lot to do and we're still standardising. So we took the decision to continue with that standardisation, even though we're in contingency plan. So it was agreed at the board that the health boards would like to really press on and further the standardisation that we've already got in LIMS 1. So the build is challenging. Biochemistry, particularly, there are 623 test sets that need to be configured, the rules done, and then tested. So at the minute, the build is a month behind. Now we're looking at that. InterSystems are bringing more resource in. We've done some automation. So we're very focused on the build stage at the moment. Once we've completed the build, in September, 2nd of September is when we go into UAT. So that's when all the health boards come together and do the UAT. We are working with the health boards as well to agree an all Wales testing approach so we can minimise the impact locally. So all health boards will have to test their local interfaces. But what we're gaining agreement with the health boards is, and this is, it's all by discipline. So we're building UAT test plans for each discipline, and in that will be the agreement of what all Wales testing is going to be undertaken. And each health board, we're deciding who's doing what at the moment, but a health board will test on behalf of Wales, and then the other health boards will only have to test, she says, even there's a lot, their local elements, their local interfaces, because we just don't have the time to repeat it, but also it makes far more sense. This is a truly national system. It is one database and one system, so that makes sense there. And then during November, again, we'll be validating the system. Now that again, a lot of work to do. We're going to be going live with blood transfusion on the system for all health boards. Now Swansea Bay are the only ones at the moment who are on blood transfusion on what we call 2016, but all health boards will be coming on it. So we've got to do national validation. There's a lot of work to do there. So we're conscious again around that, and we're working with health boards. And then in February, we start the go live. So that's when the go live starts. We're doing a joint go live with Pwllgor and Swansea Bay. Rationale behind that one is time. There's limited time, but also they're starting a South West Wales pathology service, so a hub. So this will enable them that we're looking at some of the configuration there to help with that. So LIMS 2 is a bit more of an enabler for that South West Wales pathology service. So there's some configuration that's changed to enable them to work as a hub. So another reason for Pwllgor and Swansea Bay going live at the same time. I'm just going to pause at the moment in case anybody's got any questions on that element. No. And just on benefits, so that we've got a number of benefits and they haven't been detracted from because we're in contingency plan. But I would like to just pick up on some key benefits for LIMS. And part of that is that it's a medical device certified this, so it's far more guarantees and assurances, and it's attended quality control. So that's much better for us. It wasn't before, and we were always having discussions around that validation of it. That will really help us with blood transfusion because it is a medical device, and the blood transfusion community are really pleased about that because they know that rigor and quality will be in there. I mean, there is a more modern user interface as well. Now, that hope is it will help with mobilisation of staff around Wales. So where you've got that Pwllgor Swansea Bay hub, it will all look the same. It's easy. Also, it's more like the other apps that people use now. So it's like I say, it's far more modern. So people are used to it. The analytics is built in. We always had a challenge with LIMS 1 around the analytics. It was a separate business intelligence tool, which was quite clunky. This is now all built in to Track Care Lab Enterprise. So there's a number of dashboards there that will help operationally through the health boards. And another element is there are a much stronger rules engine there. So it's not AI as such, but you can build a lot more rules in, so you can streamline a lot more and put more checks and balances in. So it's a kind of starting point to trying to automate a number of elements. And like you say, that will improve the quality and the checks. And also it's got a long life ahead of it, this product. So InterSystems are heavily investing in this product as it is their latest one, whereas LIMS 1, it is an old product now, so they're investing everything in TCLE. And in terms of go lives, as we discussed, we've got Swansea Bay and Howth are going live first. Again, it will help with their hub. We move on to Public Health Wales, and then we've got another Cardiff and Vale and Public Health Wales screening. So the Public Health Wales there is microbiology, so they'll be going live on their own. They're already a national service across Wales. And then we've got Cwmtaf and Welsh Blood, then Betsy Cadwallader, and then Aneurin and Bevan will be the last health board to go live. So the intention is they'll all be live by the end of August, as the current contract with TCL 2016 ends in September 25. So this is our assurance report. So this is what we present, and on the RAG statuses. So this is all agreed by the board. So the board agree our RAG statuses. We were a few months ago amber red, but in the board it was agreed to move to amber green because they were happy with the progress. We just had another discussion around the RAG status again at the board. We also look at all the health board RAG statuses as well, so they're presented at the board so we can make sure we're aligned. So that all goes through, and on here, say the overall RAG is amber green. Our timelines are green. Quality, now our quality is at amber green at the moment, and that's because some of the scope wasn't included in the contingency plan. So there's some elements that weren't there. So voice recognition, hemonetics and scanning wasn't part of what InterSystems were offering, mainly because of the time, although that was agreed. So we're looking at moving that to green because all the health boards have agreed the new scope and they all know what we're delivering nationally and what they need to do locally. Our resources are amber red. Now, rationale behind that is there's, like I say, limited time. So working very closely with health boards on their resources. And again, in the board, we have a RAG status for all the different elements of the programme. We RAG status it for resource across DHCW, InterSystems and all the health boards. So we know we've got a challenge on UAT. So the mitigation for that is this all Wales approach. So anything we've got, we do try and mitigate, and we present everything at the board. So all the health boards put all their RAG statuses in, and we discuss it as a group, and then at the end of the board we decide where we are. So we decided at the board today we are amber green, but we're going to do a separate risk review to make sure everybody's happy that all the risks are being managed, because as I say, there's a lot to do in a short space of time, particularly with the build. And then I said on discussing the key risks. So there's the validation, which we discussed earlier, in that there's a lot to do in a short space of time to validate, and normally it can take quite a lot of time. We're doing an awful lot of prep work ahead of this to make sure we've got all the validated elements in place, and we're working very closely with the national blood transfusion groups and the blood health oversight group as well. They're supporting us very, very heavily on this element of the blood transfusion and validation. The other one is, again, as we discussed, the resources and availability of skills. It's very busy out there, so focusing people to work on this is always a challenge, and there's multiple work streams and multiple projects. So we are focusing, again, that's with the RAG status in terms of the resources. One of the ones that we found that will come across in RISP is that LIMS 2 and RISP timelines are converging. So I'll provide a further update in the RISP element, but Philips have changed the plan. So Philips have delayed a number of their elements. So they've delayed a number of go lives, and that's delayed some of the readiness work. So now LIMS and RISP technical work are both happening at exactly the same time. So the integration, system integration, testing, all that is all happening at the same time now. So we're working, the main impact on that is the digital teams, because the operational teams are separate, but the digital teams in DHCW and out in health boards have got some challenges over this next 3 months. So again, we're working there to try and make sure we can plan this in, and where we can couple things together, we are trying to do that, because there's a number of themes going across this with encryption and cyber security. So we're trying to work it across the two programs, so we're not duplicating work where possible. And one of the things that I mentioned there, and this is the same on risk, but it is encryption. So currently the messages aren't encrypted out of the interfaces, but obviously for this new one we are doing that, and that is a challenge. Health boards have got a lot of work to do to get that encryption ready. We've agreed we won't need it for UAT, but we will need it for go live, because nobody wants to go live without that encryption. And just a couple of the issues, the blood transfusion data migration. Data migration is always a challenge. It's always a complex piece of work. We've got a number of challenges with the blood transfusion. We've got 2 legacy systems, because each health board's on their own legacy system, and then we've got 2016, so we've got 2 lots of legacy data to sort out, and that is a challenge, and the resource out there is limited in terms of that. So again, we're working on that, working with the supplier and working with the health boards to try and resolve that. There's some changes on working practice, as you'd expect in any new system, but there's some particular ones that cause the health boards quite a bit of change in terms of their working practices. One of them is this unique tube, which is very different to how it works in L2016. We've got task and finish groups there to work through that. It affects electronic test requesting, so there's a number of elements and strands to that. And then again, as we talked about, the build, the biochemistry build is the most challenging one for us at the moment. We brought more resource in. We've cancelled some training and things like that to plough the resource into the biochemistry build. And InterSystems are going to bring an extra person in next week to support that. And on lessons learned, so a couple of lessons learned that we put in there was around having visits to, when you're doing the procurement, having visits to suppliers so you can understand what's going on and really get underneath what a supplier can deliver. And that's the end of LIMS. So I'll pause in case anybody's got any questions for LIMS before I move on to RISP.
Great, thanks, Alison. Any question on LIMS for Alison? Evan?
Yeah, I just add one comment about benefits. We had a bit of a conversation about benefits in the early part of the meeting, first is about the need for us to be good at reporting benefits. So the benefits realization, arguably you could say benefits are realized whether you report them or not. Doesn't matter whether you forecast them or whether you report them, the benefits are still realized. It's just that nobody knows about them. It is really important that we capture and describe those through sensible forecasting and reporting. And the second thing is about the baseline against which you report benefits. So those benefits that Alison just went through are mostly baselined against the current system that we have. So they're an enhanced value or an enhanced benefit and outcome compared to what we're currently using. If you baseline the value of digital compared to paper, right, or no digital, then you get much larger benefits to report. And that really is the value of digital. It's the value that it adds compared to not having digital at all, as opposed to the value of the system that you happen to use before, because sometimes there can be a quite narrow benefit gain from upgrading from one system to the next. But if you took the digital away, you'd find out quite quickly how much value and how much efficiency it's delivering across the system.
Thanks, Evan. I was going to raise the same point about benefits realization and the framework and the toolkit that's coming along. Given everything else Alison's doing, that's another ask on top of pretty much a heavy workload. I just had a couple of comments I wanted to make, Alison, before you move on. So firstly, thanks enormously from this committee for the job that you've done in turning around what was a troubled programme and getting to the state it is in today, which is, you know, having gone from amber red to amber green. So well done on that. That's a remarkable achievement. Just keep it up. You've got a lot ahead of you, so if we can keep that momentum going, we'll be in good shape. The question I had was really, you mentioned briefly in the summary that InterSystems are investing heavily in this new product for them. Do we have arrangements in place beyond the implementation where we may be able to see some additional benefits from what they're investing in, either through the support contract or some sort of enhanced program of work beyond the actual program we've got in front of us at the moment?
I think on the rules engine will be the key. So obviously we're trying to get live, so they'll stand. But I think once people get used to the system and understand it, we can really build on that rules engine. I think that will be key for the work for pathology workforce. So it'll be building on that element. I'd have to have a look at any other elements that they're bringing, but for now it would definitely be that rules engine, because that can help automate some elements of it and also put checks and balances in, so less mistakes that could go through, and managing the demand more on the tests. So I think that will be the key once it's live, is building on that element for this phase.
Okay, and is that something we're able to do for ourselves, or are we dependent on the supplier for that?
No, it's there. It's all configuration within the system. We'd need advice from them on the best way to do it. But we've also in DHCW we're supporting LIMS now. So we've got there's about 6 people in the configuration team, so we can actually do that ourselves. Excellent. Okay, no, that's really good news. Good. Any more questions on LIMS? If not, we'll move on to RISP. Can't see any hands, Alison, so the floor is all yours again. Okay, so on RISP again, so the programme was established in June 2019, and this was obviously in the NHS collab, and in May 2020, I think they recognised that procurement wouldn't be completed before the end of the current supplier's contract. So what they call the termination assistance period was agreed, so to the maximum that 4 years. And then in Jan 2022, procurement commenced and the preferred supplier was picked, which was Philips. And then the programme transferred over to DHCW in Jan 2023. There were some elements that were, not an awful amount of work had been done on the implementation plan, and there were still some elements on the business case that needed to be completed. Again, we re-looked at the governance, re-looked at the team. The team were really small compared to the LIMS team, so we looked at that and brought more people in there to strengthen that team. So as we said, the preferred supplier was announced in January. We had to go through the business case. So the contract was actually signed in September 2023. And then the way the contract's arranged is this is with local deployment orders with the health board. So they actually hold the contract with the supplier. We have a master services agreement, but all the contracts are individual contracts with the health boards and the supplier. Now, what became apparent when we signed the contract, that Philips were not quite mobilised, ready for Wales. So it's taken them some time to mobilise and get the resources in place. As a result of that, we had delays on receiving a plan. So a plan was agreed for the deployment orders, but when we asked for the combined plan, because this is a radiology information management system and a PACS system at the same time, there was delays on that. So at that point, we put in very robust contract management and lessons learned from Link. We put contractual letters in place to get the plan, and we did receive the plan. And what the plan did initially was it delayed the first 3 health boards, but kept the end date the same. And then when that was reviewed, they came back and they delayed all health boards bar Cardiff and Vale and Cwmtaf. So all health boards have had their go live dates delayed, but the end of the programme is the same. So it all still ends with Cwmtaf in March 2026. So again, a bit squeezed timelines, and that's why we've ended up bumping into LIMS. So we're currently working with the supplier and the health boards. Philips have been on site and done face-to-face planning meetings with all the health boards. So all the health boards have verbally agreed their plans. We will be going to the board on the 28th of May to baseline that plan, and Philips will be actually putting contractual change notes in place for the deployment orders to realign the dates for the health boards, and that will be the contract element of it. Another thing a big focus we're doing at the moment is this transformation and standardization. So there's a big transformation piece in RISP. It's quite significant, and I'll go on to some of that when I talk about the benefits. There's an awful lot of work to do there in that transformation. We have a strong clinical lead in Sean Phillips, who is driving that forward for us as a programme, because there will be a lot of change required at the health boards. And again, we're tracking LIMS, so we expect to go into sort of UAT in September, October, and then system interface testing, and then we start the go lives again in February, the same time as LIMS, but a different health board. We managed to not go live at the same time with the same health boards. So on the benefits as well, so obviously there are a number of benefits, but I just want to pick out a couple of ones. So one is that visibility across organisations is the core of this design. So as part of this, the RIS application will provide a national view of data, and that will have the ability to create shared workflows. Now in Wales, they could always view it in WCP, but what this gives them now is they can view images, so in packs, for example, side by side, which they can't do now. They would have to go into Portal and have a look. But what this gives them is this shared record across Wales, and they can view any record across Wales and look at it side by side. So it also allows them in that is if there's sort of like, if somebody comes in one health board into A&E there, and then they're transferred and have their imaging done somewhere else, it's very easy for a consultant then to look at that, what's going on in each health board. So that is really key. The other element is within this RISP is something that Philips call Orchestrator, and we've got a big 2-day workshop in July with all the health boards led by Philips and Sean Phillips, and this will allow us to manage workflows. So if you had a case, a cardiac case or something like that, you could direct that to a specialist radiologist. So they can build those rules up, and they could direct that anywhere in Wales, and somebody could be working from home and they could do that. So that is really key for Wales around managing that. It will also recognise where somebody has capacity. So if there's underutilised personnel, it will do that as well. So that is a real significant change for Wales in this that we need to sort out. And like I say, it'll be a big change because we'll be able to manage the workload across Wales and not just in a health board. Again, this will help with those diagnostic hubs, but it will take a lot of setting up, and we're under no illusion about getting the decisions on this, and how we manage this is going to be a challenge, getting health boards to agree how we're going to manage this workload across Wales. So I say we're having a number of workshops regarding that to land it, but that is a key benefit of this programme. So again, in terms of go live dates, we are, as you can see, we are going live with Public Health Wales. Now, the rationale, Public Health Wales, they're small, limited integration. I mean, you can go either way. You can either go with your big health board first or your smaller health board first. In this one, it was decided to go with the smaller health board trust first, so Public Health Wales, limited integration. They're only using a very small part of the radiology information management system, so they're going first. Then it's Powys. Now, Powys are going second because they're going to have their own RIS and PACS for the very first time. Currently, they utilise BCU, do everything for them. So again, a significant change for Powys. So they're going next, and then it's Betsy Cadwallader. And the reason for the rationale between Powys and Betsy is because Betsy provide Powys now, so Powys going first, and then Betsy would go next. Now, Betsy, obviously, are huge health boards. This is going to be a real test for us, this go live. They've currently got 3 RIS systems, so they're running our Radis, 3 of them. So as well as going to a new RIS system, Soliton, we'll also be taking 3 into 1. So we're not underestimating the amount of work that is going to take to get us through Betsy Cadwallader, and Philips have been made well aware of the challenges with that. And then we move on to Velindre, Howth, Swansea Bay. We've got the National Imaging Academy, and Iron Bevan, Cardiff and Vale, and then Cwmtaf are at the end of that, at the end of March. Now, they chose to go last to proximity to the end of their contract, but they have asked to start earlier, as have an Iron Bevan. So a number of health boards are asking Philips if they can start their readiness activity earlier to give them a chance on getting through all this, because I think everybody recognise this is a huge programme trying to put packs. They're used to doing a packs and everything that goes with the packs, the dosing. It's the packs and a radiology system at the same time, which is going to be a significant challenge for Wales and for the supplier. So we are well aware of that one as well and working with that. Again, assurance report, the RAG statuses again are agreed at the board, so we go through this every week at the board. We're just starting here on pulling the RAG statuses from the health boards because they've only just landed the plan with Philips, so we're pulling their RAG statuses again, the same process as we do for LIMS, so we can head off any issues with resource or any particular local concerns they've got. And I said the RAG status was downgraded to red because of the lack of a plan from Philips. So that's at the last board, the request was for this to remain red, and the hope is that we will be able to increase this to amber red in May once health boards baseline the plan and they've got a plan. The timelines, again, because of the delays with Philips and the delays on the plan, that's amber. And then the quality, the scope remains the same. There's no change to the scope. We're delivering what was said in the FBC, and nobody's raised any concerns around that. On the resources, there were a couple of elements in the funding that were missed off at the FBC. They're not significant, but we are looking at that. The only new thing that came out as a result of the changes to the plans from Philips is it does move the capital monies we receive from Welsh Government across years, which we know can be a challenge for Welsh Government. So we're going to work with Welsh Government and see what that means, because it's now tipped 2 health boards payments into another financial year. So we've got to work on that with Welsh Government and Philips. And then the key risks for RISP. We've had a real challenge with the PSBA connectivity, which is an NHS Wales responsibility. We've had quite a challenge working through this with PSBA, with BT, with OpenReach. It's quite a protracted process and quite complex. So this is sitting in Philips data centres. So we've had to do site visits. We need to put another route in that goes across private land, so having to get the landlord to sign this off. We've utilised Welsh Government have an escalation route into PSBA, so we're meeting with Welsh Government every week trying to get these dates in. We need these dates set up by September, so that's been a real challenge for us. And again, resource, it's the same theme across the programmes. There's a lot to do in a short space of time. So again, it's aligning all those resources around that. The other one to note was just what I noticed with the emerging costs, and now the added element of potentially having to move Welsh Government funding across financial years. In terms of issues, this has actually been resolved now. It was resolved on Monday. The Coda connections is all about the cyber security. So that was critical for the transfer of data. So we've worked on that. There's some elements in terms of MPI and the data migration. That's another significant task for us, the data migration from our legacy radiology system into the new Soliton system. So we're working through that. And lessons learned. Now, these are the lessons that we took from Link. So that early escalation to the supplier, which we did very early on. We had escalation meetings with the managing director of Philips, with Michelle and Helen Thomas, to press home our concerns. And as a result of that, they have increased the resource, Philips, so there's a lot more resource. They now have a big technical team that are actually based in Liverpool, but obviously we'll travel as required. So that did work, because we got the plan and we've got the additional resource. The other thing we're really focusing on is making sure health boards are well aware of what they need to do and giving them lots of notice to get it done, because they've got such a lot to do. So we're absolutely clear around what they need to do, what resource they need, what type of resource, and when they need it by. And then the PSPA, which we've already discussed, that's been quite a challenge getting that through. And then one thing I just wanted to focus on is what we're trying to do across the programs is how we're managing our engagement and our resource. So on our clinical support for LIMS, we've got a national clinical strategy group, and that's chaired by Andar Gunnerberg from Swansea Bay. We also have multiple what we're called scientific advisory groups. They're all discipline specific. And then we have a senior responsible owner for blood transfusion, but we've also have the blood health national oversight group who are key in terms of our governance. And then on project management, so we've got a national team in place in terms of running this, obviously in DHCW, and it's centrally funded, and we've got the contract as well in DHCW, so it makes it slightly different. So there's a lot heavier presence, I guess, program management on LIMS than there is on RISP. And that notes with the national team, because we support LIMS now. We've got a support team. It's on our infrastructure, and we do the configuration. We'll continue to do that configuration, but the infrastructure will be sat on the supplier's infrastructure. So on RISP, again, we've got a national clinical lead in place, which is Sian Phillips. So she's leading that standardisation and transformation group. We're looking at having a clinical, what we're calling a clinical reference group. So we're going to be pulling that together and bringing that up. We work very closely with the National Imaging Academy. They've been very supportive and very helpful just in terms of holding national meetings, and also with the National Imaging Programme. So we're working very closely with those two programmes in terms of delivery of this. So the project management, so national team, again, it's DHCW, and we are leading on obviously the national delivery, and it's centrally funded, but there are local project management boards in place, as there are in LIMS, but the contractual ownership does sit with the health boards and Philips, as we don't have that contract. So we are supporting the health boards in that. We've actually set up a national contract management group to support them, and also our commercial team have developed a set of a sort of training guide for health boards, so they can understand about managing their contracts, because robust contract management is absolutely key, as we hear across all these programs. So we're really putting a lot of effort and support in with the health boards so they can manage their local contracts efficiently. As I said, the national team is limited compared to the LIMS national team, because all the contractual elements do sit with the health boards and Philips. However, as I said, we are heavily supporting them on all aspects of that. And again, with the support, even though our support is limited to integration and connectivity, we are looking at how we can further help support the health boards so you know, they understand what they've got to do in terms of the contract. And they've also got local health boards in place, and we have set up, same as LIMS, we have a national implementation steering group, so all those implementation issues can come there. So we are heavily supporting the health boards in making them self-sufficient in terms of their contract, and then ongoing management of this once we're live. And that's the end of my presentation.
Excellent. Thanks very much, Alison. Very concise, a lot of information in there. Any questions on the RISP programme for Alison? Okay, can't see any hands up, so I'll ask my question. Evan, you've got your hand up.
You go first, David, if you could, because I wanted just to close with something, reflection on the two programmes together.
Oh, fine. Okay, good. So, Alison, when you were describing the fact that we've now got some overlap between the two programs, based on what you said, I think that's a direct result of Philips' delay in mobilisation and then compressing the implementation plan for rollout across headboard. Have I understood that correctly?
Yeah, that definitely contribute. I mean, we had an issue obviously because of the delay in LIMS or Link as was, but then we were managing it. Although we were tracking the same, the technical aspects didn't overlap the same. We had some gaps, but as a result of Philips changing their plans, they're now exactly at the same time, the technical elements.
Right. Okay. So I think that risk manifests itself in Health Board digital resources having to basically support 2 rollouts in their patch. Is if I understood that correctly as well?
Yeah.
Yeah. Okay. Fine. And have we got any feedback from the health boards in terms of that? That's obviously increased their workload. Can they manage that, or are we likely to get some delays as a result of trying to do 2 big programs at the same time?
So they have said it's a challenge. Now, they haven't said they can't manage it, because that's what we work through with the board. So in the boards for each element, we ask for their we rag status it, same as we do red, amber, green. And on each element, we're asking them, have you got sufficient resources? And for example, there was one health board that had a red for their resources, so we pushed on that, and they escalated, and they got additional resource and additional funding.
Yeah.
So at the moment, no one said they cannot do it, but we are pushing hard. If anybody marks red, then that's raised at the board, and we go through that escalation, and we ask health boards to escalate through their health board where they've got issues on resources.
Okay, that's great. And then the other question I had was around the fact that because we got this new system, we can actually get radiologists in different health boards looking at results from different, which I think is a great improvement. And the only concern I've got is whether the health boards are fully on board with that. If they've got scarce resources, are they going to be happy with having to do work for another health board when they've got limited capacity? That's one question. I guess I know the answer to that, but I'll leave you to respond. And then the other thing that occurred to me is I've seen elsewhere that possibly in England, but I might have misunderstood this, but they're actually getting radiologists in Australia to look at some of their imaging and sort of offshoring, for want of a better term, some of the work. Is that an option that we've built into the system in terms of the security that you've alluded to in your presentation?
So we haven't been asked that. So cyber, obviously we've got all our cyber security in place. What is normally an issue for NHS Wales is anything outside of Europe normally causes us a problem.
Okay.
So we'd have to look into that in terms of the data. So we'd have to look into that. But the system is available. But it would be what our rules were in terms of cyber and data access.
Yeah. Okay, so it's an IG issue, right? Sorry, information governance issue rather than okay.
Yeah, and picking up on the around the scarce resources. I mean, part of the reason for Orchestrator is to manage that scarce resource. So if one health board hasn't got much resource and another one has resources that are underutilized, then that's where this is what this is supposed to be able to do. But it is going to be a challenge for health boards to agree how they're going to manage that, and that moving that workforce around Wales. And we're very alive to that. Hence Sean Phillips is looking at this, and we've got this big workshop in July to really start fleshing that out.
Okay, that's really good. Okay, I can't see any other hands other than Evan, so I'll hand back to you, Evan, for a bit of a summary on the 2 assurance reports.
Very much. I just want to bring a few things back to some of the things that we were discussing earlier on this morning. The first and most important thing is that the reason we're bringing these reports is to provide assurance to the Programmes Delivery Committee, and it is an assurance function. That's its governance role. Personally, right, I take a high degree of assurance from what Alison has just presented. Yes, it was concise, but there is so much work under the hood there, and there are a few things that I think we can take a level of confidence from in the way that it's being reported back and where those programs are at, and particularly something we'll talk about at the end, which is the close working with health boards. There's so much in the slides, it's quite easy to skate over or to lose sight of how long these programs resided in the collaborative before they were handed across to us. So LIMS was 4 years in procurement from 2017 to 2021. RISP was 3.5 years from procurement in the collaborative before they came to us. And we've now got quite a challenging, we've got a very, very challenging timetable for implementation if you like, in the second half or in the back end of those programs. I think it's something for us to look at as a whole system as to how long it takes for us to do those. LIMS will be 7 years, 7 and a bit years end to end. and RISP will be something similar. That is a very, very long time, and it means that the minute we finish deploying something, we've effectively got to start reprocuring the next version or iteration of that same program, and that is, and it costs a lot of money to run programs, and program teams and all the other work that goes around them. So that's something that we need to look at collectively as a system, I think, and it's I constantly have to remind myself just how long some of these programs have been going around, because they weren't being delivered by DHW, they were being delivered by others before that. I think there's a good example, especially in the RISP dashboard report, of RAG rating and how we're seeing different interpretations of the RAG framework. So the RISP program is rating itself on overall delivery confidence of red because of the delay in the supplier plan and the impact on some health boards' delivery implementation dates. But it says clearly that the overall implementation timetable is protected. That is, the overall completion plan date is protected. The definition of red in the framework is, and I'm quoting here, right, no confidence of successful delivery requiring critical decisive action and major issues which do not appear to be manageable or resolvable. So that red RAG rating doesn't reflect that, right? It says, we've got things we've got to deal with, but we will still manage to hit the overall program timetable. And that is quite different to what the actual RAG framework says about what a red rating is. That's not a no confidence. So I think we've got lots of work still to do on getting consistency of RAG reporting, because program boards report, for more than the reasons that are in the framework. There's a whole bunch of other things at play. None of that, though, undermines what comes really through so strongly in those last two updates about the overwhelming importance of our close working with health boards. The way that these two programs have had to get really, really close to the implementation teams, with a huge amount of coordination on the implementation timelines, the order in which health boards implement, the synchronization between the two to make sure that a health board isn't implementing both at the same time. I think it really shines through, and there are a couple of things that are really, really welcome. The on the user acceptance testing for LIMS, sort of a collective decision to allow individual health boards to lead on behalf of the whole system. That is really important, because we've stumbled or got into so much trouble in other programs where each health board does its own UAT and come to quite divergent views on the safety or acceptability of the same program in different parts of Wales. And then the national contract support, which is being put in place for RISP. Robust supplier contract management is really, really important. And it's important that we're on the front foot and that we identify any issues very, very quickly, and then we work with the suppliers to resolve them. And there's more experience in DHCW of managing these types of digital contracts and having those important relationships with suppliers than there is in health boards necessarily, right? Because we do this all the time. So it's really welcome to see that. And this, as Alison said right at the beginning, in LIMS, for example, the 2-year timetable has really focused minds. And they say never let a crisis go to waste. I wouldn't have wished for a crisis. None of us would have wished for a crisis. But if we've got that crisis and we've got that timetable, then there's always a silver lining, and there are some benefits to or some advantages to the way that it's playing out. So I think thank you very much, Alison, for the update on those two programs, and thanks to you and to the teams for the work that you're doing on them.
Thanks, Stephen. If I could add to what you've said, I'd also I'd like to thank Michelle for all of the good work that was done when these things moved over from the collaborative. Without some of that engagement with the suppliers, we'd have never got to the position where Alison could pick up what was a bit of a hospital pass, frankly, and turn it around. And the point you made about the RAG status being slightly inconsistent, I fully understand why that's the case, but maybe that's something you could bring up with the independent oversight chairs, if I've got that term correct. I think you said you've got a session coming up. That may be something that you can add to the agenda, which I'm sure you were thinking about anyway. So unless anybody's got anything else they wanted to raise on RISP and LIMS, then I think we're done with that part. I think we are assured, Alison, you're doing a grand job with what was a very difficult programme. So please continue the good work, and hopefully the next time we see you've got through a load more difficult work and we'll be at the other side of the programme. So many thanks again for your perseverance with these two programmes.
Thank you.
Okay, so we're running ahead of schedule, which is great. We'll move to closing matters. A or B, I've not been made aware of any other business before the meeting, so I'll just pause and see if anybody's got anything they want to raise. No, okay. Chair's highlights report. I've made a note of a number of things that I think I will include, but I'll work with the governance team and even just to make sure we've got a consistent view of things that are wanting to raise. I think the overall funding status, the state of the programmes, fact we need to re-baseline, some highlights from the LIMS and RISPs, I think are the sort of things that we'll likely put into the report. But we'll do that as part of the minutes and the chair's highlight report that'll go to the board. With that, I'll bring this meeting to a close. The next meeting is on the 1st of August. I'd like to thank everybody for attending today and for the open, transparent way that we've conducted business. The recording of this will be available shortly after we've concluded today. So I'll now bring this meeting to a close. Thank everybody. Jochen Vau. Cheers.